Hello, everybody. First of all, I'd like to thank Neil and the organizers for including me in this first Emirates conference on palliative care. It's a great honor to take my place among this star lineup. I'll try to do justice to the invitation and explain in a very short time what advocacy for a world free from health-related suffering actually consists in. For more information, because I'm just going to give you a very rapid bird's eye view, please visit our website and join the IAHPC so that you can advocate with our delegations at multilateral meetings. So I've ticked the second two bullet points because it's in these two institutional affiliations that authorize us to advocate at the United Nations at that system level. The IAHPC is a global membership organization. We've been legally registered in the U.S. since 2002. We're in official relations with the World Health Organization, and we're in consultative status with the UN Economic and Social Council. We have a global board of directors, and we have 4 pillars of work: education, advocacy, research, and information dissemination. Our vision is a world free from health-related suffering, and our mission is to serve as a global platform to inspire, inform, and empower individuals, governments, and organizations to increase access to and optimize the practice of palliative care. And that's a consensus vision and mission statement that we came to through our strategic planning with the board. So IAHPC advocacy and public health advocacy in general is done through accredited civil society organizations, not by individuals acting on their own. And civil society advocacy organizations such as the International Association for Hospice and Palliative Care have a recognized legal right to participate in UN organizations. And this is straight from the UN website, that it says we play a vital role as partners in the UN in implementing the development goals and assisting people at the local level in countries across the globe. So it recognizes our value. And I also think of it, and you're all medical people, so you'll understand this, that advocacy is really like being connective tissue or synapses between impacted populations, and that's your patients essentially, and policymakers. And by impacted populations, they're impacted by disease, by poverty, by lack of access to palliative care, lack of access to medicines, proper food, trauma, war, climate change, you name it. We advocate by sending delegations who represent those patients and impacted populations and caregivers to multilateral meetings. Those are international meetings in the UN system. And they're delegates who are our members, who have some expertise in particular subjects and who's volunteered to go. And anyone who's a member of IAHPC can apply to join a delegation to one of these meetings. Unfortunately, we don't have very much money. We're very limited in our funding, so all our delegations have been self-funded. But they're all full. We have full delegations at all the meetings, so there's tremendous desire to participate and do this. And I mentor those delegations through the meetings. You're not going to go in there cold, don't worry. The other thing is that advocacy is distinct from lobbying. It's quite a different process. So a more lay description in common language rather than the more technical language I've been giving you is that in terms of the principles of advocacy, it's really a form of faithfulness, even doggedness, never giving up. Advocates show up with evidence and testimony in any place where we might be able to build influence and relationships with decision makers. We take the long view. We don't expect short-term results. We're often out of our comfort zones because that's where the growth is, as the cliche says. And just like palliative care practice, advocacy is interdisciplinary and multidisciplinary. We build trust within and outside our teams with our conversation partners in government. And I love thinking of it as love with its sleeves rolled up, really, or love in action, love of our communities, our patients, our families, and one another. So that's the informal definition. But more formally speaking, that love in action gives voice to suffering. And the etymology of advocacy and its meaning for palliative care, it comes from the Latin ad and voc, which means to give voice to. And what do we give voice to in advocacy? To health-related suffering. And so as practitioners, you as advocates give voice to your patients and to their families' suffering when you advocate. But first you have to educate yourself about your audience. Who are you speaking to? About the situation in your country, the statistics in terms of health-related suffering. And then you proclaim. That's what advocacy is, proclaiming. And you invite policymakers into conversation, as the photo shows me doing. I'm proclaiming at the World Health Assembly in Geneva. I'm giving a statement. And then you invite your policymakers and other influencers into conversation on the topic. Advocacy is an ongoing process of building relationships. It's not a one-off. That's why I said we take the long view. And this conference itself can be a work of advocacy as you educate yourself with your expert speakers, and then you proclaim to your policymakers that you have learned this and that this is what you would like to institutionalize in your country, your health system, your hospital, whatever your setting is. So you go forth and enter into relationships with new conversation partners who can take steps to integrate palliative care into those institutions or health systems, so that it's not a luxury for the fortunate few who can afford it or who have insurance. We advocate for public health palliative care as a public good. And the World Health Organization actually calls palliative care a global public good. So we need to be clear about how suffering, health-related suffering, fits into this global public good. It's not suffering per se in the Buddhist sense of the first noble truth that all life is suffering. That's distinct, but it's IAHPC's vision is a world free from health-related suffering, which is based on the consensus definition that you can find on our website, created by global practitioners, some of whom are at this conference, through a Delphi process, and it's based on the original, or revised, I would say, 2002 WHO definition, which has quite a few components. And it has those, you can read those elements and components on our website. But the definition of palliative care is active, holistic care of individuals across all ages, so from neonates to older people, with serious health-related suffering due to severe illness, and especially those near the end of life. So health-related suffering, and this is the definition, is associated with illness or injury of any kind, and it's serious when it cannot be relieved without professional intervention, and it compromises physical, social, spiritual, or emotional functioning. And that definition is our North Star of advocacy. So now we've described the what we advocate for. Let's look at the where and the how of advocacy. So we advocate at local, national, regional, international. Those are the multilateral spaces of power. We do it, as I said, through relationship building, and that this entails understanding the institutions, the policy and the politics of the place where we're advocating, and connecting impacted populations, as I've described that already, with decision makers. And we have to understand the goals and influence local, national, regional, and international policy. In other words, we read the agendas, we understand the goals of the policymakers, and we try to align our message with the goals. So that's a lot of compressed information, which is why you get a copy of the slides later. My presentation is largely focused on international policy, since the multilateral system authorizes and legitimizes regional, national, and local policy. So we are at that level, and we try to legitimize the policy making at all those other levels. What is the multilateral system? It's a system with many sides, as the word suggests, and it's part of the UN government structure, which is member state driven. It's always driven by member states, 194 of them, each of which has one vote, at least technically, in the system. Civil society organizations, as I've said, are part of that. We're recognized part of it, but we can't vote. We can just consult. There are many functional agencies and organizations with secretariats, and these are the main ones we advocate in at the World Health Organization, the Commission on Narcotic Drugs, and the Human Rights Council. Because these are the organizations that create and oversee the evolving global normative framework, which now includes palliative care. So this is the sphere of influence where the IAHPC works, because we're institutionally affiliated with the UN, as I said in the beginning. And at the UN, as a result of more than a decade of advocacy at this level, representatives of your governments, because this is an international conference, which also make the laws and policies of your countries, have created what's called a normative framework to support palliative care and access to palliative care medicines. A normative framework is just a term of art, which means all the different laws and policies which they have committed to. And as civil society organizations advocating at the UN, we participate in the meetings, but as I said, we can't vote. And what we do is we bring back the accomplishments that we've had, and I'll go to those in a minute, to the national and regional, like this conference is a regional sphere of influence, so that then you can use them in turn in your spheres of influence. So the global normative framework is the human rights laws and covenants. These are evolving Human Rights Council and Office of High Commissioner documents. The covenants were usually agreed to in the mid-1960s, 70s, but there are documents which update them. And one of those was what's called General Comment 14, of the Office of on the Covenant of Economic, Social, and Cultural Rights, which includes palliative care as part of the right to health. So that's what I mean by evolving. Then there's global and public health law, which is the World Health Organization is the secretariat. Drug policy, which is overseen by the Commission on Narcotic Drugs. That's where the medicines are overseen that we use. The rights of older persons, the open-ended working group on aging appointed by the General Assembly, and the participatory rights of civil society are overseen by the Economic and Social Council, or ECOSOC. So this is the global normative framework that authorizes and legitimates the national laws that in turn authorize and legitimate your bedside practice. And it's always aspirational. It's important to remember that. It's approved by representatives of all the world's governments, but it has to be implemented at the ground level as a result of advocacy by practitioners such as yourself. It's not self-implementing or self-executing. It doesn't just happen. Your advocacy at the national level and the regional level is what makes happen what we do at the international level. The normative framework consists, as I said, of human rights covenants that set down standards that are agreed on at the Human Rights Council and the Office of the High Commissioner for Human Rights. And our advocacy has now included older persons' rights to palliative care in resolutions at the Human Rights Council, declarations of the Commission on Narcotic Drugs, and it's part of the discourse now at the General Assembly in terms of older persons' rights too. So these are some selective global advocacy accomplishments that we have accomplished with our partners. It's always collaborative. And other global associations over the years, starting, of course, with, see how recent this is, just 10 years. The 2014 World Health Assembly resolution, this is the 10th anniversary. 2016 was a really important year for availability of controlled medicines in terms of our advocacy, but that again has to be implemented at the local and regional level. 2018, the Astana Declaration on Primary Health Care, which originally did not include palliative care because of our advocacy, it now does, and palliative care is now officially part of primary health care. 2019 to 2023, there are several declarations on universal health coverage, which now include palliative care. 2021, there was a Human Rights Council resolution on older persons, which now includes palliative care. And then in 2023, there was the Commission on Narcotic Drugs joint call to action on essential medicines. And also last year, the draft pandemic treaty on preparedness and response, because of our advocacy, now includes palliative care. So there has to be uptake through the national and regional organizations and associations of palliative care in order to enact those accomplishments so that it reaches the bedside. And these are the levels of governance for PC advocacy, palliative care advocacy, These levels are all interactive and dynamic to some extent, and I wish I were clever enough to design it in an interactive way or use AI tools to demonstrate that, but I'm not. There are some barriers, though, for instance, at the national level and the regional associations on the right. So these are all the regional and national associations and some global. The globals are up here. These are the regionals, and these are just some selected. There are too many to include. National associations. The national associations cannot advocate at this level. Only we can do that. The regional associations cannot advocate at this level either. So everyone sort of has to stay in their lane. But they all have to be accredited with the national government, the regional level, or the international level. And if they're properly registered to advocate at the corresponding national or regional level, then they must enter into some sort of accreditation so they can influence the member states and governance at that level. So that's another important piece, is to understand which level you're accredited to and where you can advocate. And if you want to advocate internationally, that's why I said you need to join IAHPC to advocate with us. But there's no one-size-all formula for advocacy. It's an institutional process, and it requires attention to the various parts of each institution. So I can't just say this is what you should do for your institution. You have to find that out and do the research on that. So there are phases in context of advocacy development. There's the pioneer, fire in the belly leadership right at the beginning, which doesn't require an institution or an association. And then there's the sort of middle phase, or the settler phase, as it's called in business advocacy, business theory, where you gather like-minded professionals, you study, you join other associations, and then you consult. And then later, there's what's called in business theory, again, the town planner phase, where you consolidate what's gone before. You recruit board members, you create and register institutions, you develop strategic plans, and you identify advocacy focal points. Most EMRO countries are still in the developing or capacity building stages, according to the 2021 Global Atlas of Palliative Care, and most still have insufficient availability of controlled medicines. Some don't, some have good availability, but the ones that don't means that you need to generate and gear your advocacy to your context. So where there's no association, build one. Include in your advocacy your strategic plans, and IHPC consults with our members, institutionally and individual, to help you do that. These phases of influence can be described in terms of, again, a dynamic process, so you amplify your spheres of influence. We accomplish the goals we discussed earlier, those accomplishments, by amplifying our spheres of influence at the global level through partnerships with other global, regional, and national institutions that were already established, because obviously we couldn't build other institutions. So we amplified our spheres of influence. Many of you would probably describe your professional circles of influences as limited to your patients and their families and your colleagues within the institution. That would be here. And then advocacy expands that to your institutions, so that you're then advocating in your institutions, beginning with your professional associations, even maybe persuading your palliative care association, which is heretofore focused on clinical education, to consider doing advocacy, which can be very influential in some countries. Then you widen your sphere of influence to your city, your district, your province, and then you get the picture to your country, and then to the multilateral sphere. You do that by building up your influence with other organizations and influences, including the media. Some advocates have been very successful with the media to create public awareness about the need for palliative care. So when you do that, you're creating what's called a virtuous circle, whereby each circle increases the benefit to the next circle. And I'm going to explain the structure of the multilateral level, which is where IHPC has influence, but only because the circles build in a dramatic and, I have explained that already, in a dramatic and synergistic, dynamic, not dramatic, way. These are our main advocacy challenges: the opioid phobia, the North American opioid crisis, which has gained so much publicity, has really retarded a lot of our efforts to improve availability of controlled medicines, because so many countries that really want to improve availability are afraid they'll have the same public health crisis. So we're really working on that with the UN Office of Drugs and Crime, and a recent meeting we had on diversion of controlled medicines. Global pharmaceutical marketing is a big challenge, because they only want to market the profitable medicines, not morphine, which is not profitable. But there are strategies that can counteract that. Many misunderstandings about palliative care, which I'm sure you're all familiar with, the main ones being it's only for cancer, only for the end of life. The policy focus in global health on saving lives rather than taking care of the people whose lives cannot be saved has been a real problem for us in global health. And most recently, the very well-funded global euthanasia movement, which also has a connection with lack of funding for advocacy. Because as more investment goes into assisted dying and euthanasia in some countries, there's a corresponding lack of funding, and there's now some evidence for this in Canada and Australia, that there's a lack of funding for palliative care, disinvestment in palliative care, but there's a real lack of funding for advocacy that we have been dealing with. So some takeaways: determine your context and your phase of institutional development, so then you can decide which level to advocate at. Identify and expand your spheres of influence slowly and systematically. Assess population needs and engage in strategic planning. And there's lots of really good data coming out on population needs and health-related suffering. Engage in strategic planning with your association. And of course, join IAHPC because we can help you with a lot of that. We've got courses for our members on pain and symptom management as well as on advocacy. So thank you, thank you, thank you. Please join our global movement. This is the website. The QR code also gives you access. That's my email. I welcome your